Dr. Trejo Gutierrez really set this talk up so well. But as we kind of shift the course into talking about more focused management of obesity, I thought this year that we would start by showing the impact the COVID pandemic has had on the obese individuals. Again, these are my disclosures, nothing pertinent for this presentation, but I do have grants for some of my other work from Nestle, Fresenius, Real Food Blends, and Vective Bio, as you can see there. These will be the main learning objectives. Really what I'll try to do is focus on the impact of obesity on outcomes with COVID-19, and then try to build the story of why this is occurring, with some of the structural changes that are associated with obesity, as well as some of the immunologic and cellular level changes in the adipose tissue itself. So let's start with a case, to ground ourselves. This is a 75-year-old female with heart disease, preserved ejection fraction, heart failure, obesity complicated by type 2 diabetes, hypertension, who presents to the emergency department with 5 days of shortness of breath, exertion, cough, fever, anorexia, and fatigue. In the emergency department, she's quite ill. She's confused, tachypnic, hypoxemic. Her oxygen saturation is down to 80% despite being on O2 via nasal cannula, and she's febrile. So because of this, she's intubated, but again becomes hypotensive, requiring pressors. CT of the chest is done, and it shows dense bilateral lower lobe infiltrates. And I kind of ruined the punchline here by the title of the talk, but she's positive for SARS-CoV-2. And so as we start, which of these comorbidities and risk factors are associated with worse outcomes with COVID-19? Is it obesity, diabetes, cardiovascular disease, age, or all of the above? So I'll give some time for responses. And as most of you guessed, it is all of the above. And I'll share some of the data that we've seen for this. And early on, obviously, much of the data for COVID-19 was emerging from Wuhan, China. So some of the early reports with over 70,000 cases looked at, what was associated with mortality. And what they found was that age, as you can see here, age distribution, spectrum of disease, these were all risk factors for mortality with COVID-19. They also noted that roughly 10.5% of these individuals had cardiovascular disease, about 7% had diabetes, and then obviously chronic respiratory disease, hypertension, and cancer were all risk factors. Then as the virus kind of shifted towards Europe, especially Italy being hard hit, we started to look at their data. Their age, again, showed up as a bigger risk factor. But what we saw was that the Italian population tended to be much older than the Chinese population. Roughly 23% of the Italian population is age 65 or older. And so they predominantly represented higher numbers of cases there. They also did sub-analysis of death again and looked at same sort of comorbidities such as diabetes, heart disease, atrial fibrillation, cancer, but dementia also in this age population started to emerge as a risk factor. Then as the virus kind of shifted and we started to see other countries reporting their data, this data is from over 20,000 individuals from the UK who were admitted for COVID-19. We started to see finally that obesity was starting to emerge as a risk factor. Again, perhaps correlating with the prevalence of obesity in those countries. So you can see age remained a big factor for admission with COVID-19. These were some of the symptoms that were described: cough, fever, shortness of breath, fatigue being the most common. But here are some of the comorbidities that were associated with hospitalization with COVID-19. When they started to do meta-analyses, when they started to do multivariate analyses, that's when you started to see obesity really emerge as one of the strong risk factors for admission. Here, the hazard ratio is 1.33, and that's higher actually than even pulmonary disease. Age, again, above 80 especially, remained a big risk factor throughout all of this. New York data, same thing. So this is over 5,000 individuals who were positive for SARS-CoV-2. Out of those, roughly half required hospitalization. And if you remember from this time, we really had constrained testing, and so some of our sicker patients were the ones being tested. But half were hospitalized, and out of those, roughly 1,000 patients became critically ill. And again, looking at the risk factors, busy slide, but age remained a risk factor, but then obesity started to become a big risk factor, especially when you started to control for other variables. So those with BMI greater than 40 were more likely to become critically ill and more likely to die from COVID-19. Other studies showed the same sort of pattern. Obese individuals compared to their normal weight counterparts were almost twice as likely to be hospitalized, almost 1.8 times as likely to require mechanical ventilation ICU admission. And so let's shift then to what are some of the physiologic changes that then lead these obese individuals to having worse outcomes with COVID-19. In this question, I've sort of reversed that. So which of these changes are not associated with obesity and implicated in poor outcomes with COVID-19?